Hi, I'm Michael MacGregor. I'm in the Department of Psychology, and I'm a clinical psychologist. I'm basically involved in two types of research at the university. Broadly speaking, research related to mental health and research related to physical health. But as a clinical psychologist, I have an aspect that I'm interested in that connects those two fields. And the aspect or the domain is personality. What are the individual differences? What are the unique components that people have? What are the aspects of mental functioning that allow us to better understand or better predict or better assess aspects of physical health and aspects of mental health? So let me give you an example. In terms of physical health, I'm interested in risk factors for hypertension, so high blood pressure. What type of actions do people engage in that lead to or may be associated with high blood pressure? So I'm not interested in the medical component. What I'm interested in is the psychological component. So what I study is anger. How is it that people deal with their anger? Do they keep their anger in? Do they let their anger out? Do they do something constructive with their anger? Do they go to the gym? What is it that people uniquely do with their anger that may or may not lead to hypertension or high blood pressure or health risks down the road? The particular aspect I'm interested in is constructive anger. How do people constructively deal with their anger? So when faced with a situation, how do they deal with it? Do they take a destructive way? Do they vent? Do they yell? Or do they take a constructive way of approaching that anger? Do they try and resolve the situation? Do they try and come to an understanding of what provoked that situation? Do they try and have a better understanding of the other people involved? If they do, that's what we consider constructive anger. And what I found in my research, along with many other people, is that those people who engage in constructive use of their anger or try to constructively deal with their anger have a quicker return to baseline blood pressure when they're provoked. So if you and I are provoked, our blood pressure is going to go up. We're going to get stressed, our blood pressure will raise. The question is then, when does it come back to baseline? How long are we elevated for? And what we find is those people who destructively deal with their anger stay elevated for a much longer period of time than those people who deal constructively with their anger. Now, if you're 20 years old or 25-year-old or even 30 years old, that's probably not a big deal. But over the lifetime, over years and years and decades, if you continue to have your blood pressure elevated at that level, it causes a greater and greater toll on your body. And the example I always use is a garden hose. If you turn on a garden hose and there's no way for the water to get out, it just sits there, there's pressure in the hose, and for the first year it's fine, and you leave it there in the winter and you drive over it with a lawnmower a couple times, you step on it. If you just keep the pressure in that hose without releasing it, eventually it'll wear it down. The same thing happens to our body. And that's what we do if we destructively deal with our anger. If we constructively deal with our anger, we let it out, we try and deal with the situation, we release the pressure, it's like letting the water out of the hose. So that's my one area of research, or an example of my one area of research. The other area of research that I indicated is mental health. So again, broadly speaking, I'm interested in mental health. But as a clinical psychologist, I'm interested in the personality components that predict mental health, the individual components that predict mental health. So what is it that puts one person at a risk for developing a mental health issue and not another person? Or if we have two people and they both have a particular type of mental health issue, why does one go on to develop a more severe form of it compared to the other? So let me give you an example of that. The way that I look at those components is I try and understand what individual ways of coping people use at an unconscious level to deal with their stress. So when you're stressed or you're faced with a stressor, what is it that you do unconsciously, out of your awareness, that allows you to deal with that? And how is that related to mental illness? And the term for that is defense mechanisms. So what are your unconscious defense mechanisms and how are they related to mental health? And we've worked in a number of areas in my lab, looking at defense mechanisms, those unconscious coping and anxiety, or defense mechanisms and depression, defense mechanisms and personality. And what we find is that those people who engage or use unconsciously less adaptive defenses, so dissociation, acting out, splitting, psychotic denial, even some forms of repression, are more likely to have severe symptoms or more likely to show different forms of psychopathology compared to those who don't. So that's an example of how I look at individual differences. Now, I've also said that I'm a clinical psychologist. So as a clinical psychologist, I also work with patients. I'm trained to assess, treat, and diagnose different aspects of psychopathology and mental illness. Although I have experience working with all different types of mental illness, I really focus my attention, my clinical skills, on those problems that are long-standing and severe. So, for example, I focus on personality disorders, borderline personality disorder. And I try and help people with this long-standing, stable, pathological or atypical way of relating to others. And I do that through therapy, long-term therapy. Maybe once a week, maybe even twice a week for at least a year or for 2 years. So that might be the type of issue I deal with in terms of personality disorders. Also deal with eating disorders, for example. So what are the things that I can do as a clinician to help somebody with an eating disorder? And I always tell people when I talk about mental illness, a lot of times, in many situations, people don't just wake up one day and have this severe type of mental illness. It's been laid down over months, over years, from a very long period of time. My job is to help that person uncover how it's been laid down and to help them reshape those experiences so ultimately they end up happier, functioning better, and having less severe symptoms. So that's two examples, or those are two examples of the type of clinical work that I do. Now, I'm also a professor, so I teach in the Department of Psychology. At the undergraduate level, I teach introductory psychology. So we have 2 courses in introductory psychology, the biological and cognitive foundations of psychology, and then the social, clinical, developmental foundations of psychology. And I teach both those courses. I take a very different approach to teaching than probably most psychology professors, here or at other universities. So every topic that we cover, whether it's the methods of psychology, mental illness, motivation and emotion, or intelligence, I cover 4 different ways. The first way that I cover it is I give a general overview lecture. So I tell you why the content from that area or that chapter is together the way that it is. What is the history of psychology related to intelligence testing? Or where did intelligence testing come from? So I tell students that story so they understand where that area has come from and how it fits together. That's a traditional lecture. Most people will experience that. The remaining ways that I cover that material, however, is very different. The second way that I cover it is through what I call an in-depth approach. So I'll take one aspect of that chapter, or one aspect of that content, and cover it in depth, go beyond what the textbook talks about. So if we use intelligence testing, maybe I'll talk about the history of intelligence testing. How was intelligence testing used, for example, in the First World War? How was intelligence testing used in the Second World War? Did you know that most people today, if they took an intelligence test that was used in the First World War, would probably fail? And the reason is the tests that were constructed were biased. Biased for the time, biased for the period. So I might talk about that, for example. I'll go into it in great detail, talk about the history of intelligence testing. That's the second way that I would cover the content. The third way that I'll cover the content is what I call inaction. So you read about it in the textbook, you've heard me lecture, you learned a little bit about the history. How does it apply to everyday life? What's the importance of intelligence to your life? This is where I try and make what I talk about in class, what you read about, real. So using the intelligence example, I actually bring an intelligence test into class. and I ask for volunteers, and we work our way through the different components in the intelligence test. And that way you can see how it is that intelligence is really assessed. Then we talk about how intelligence tests have been used or misused, both currently and perhaps in our recent past. For example, a number of authors will tell you that there are racial differences in intelligence, and they actually rank intelligence by racial group. At the top you have Asians, in the middle you have Caucasians, and at the bottom you have Africans. And they will say that this is genetic. But remember how I talked about the problems with testing in the First World War, the bias in testing? We have the same problem here. People today are still trying to make that type of argument. Now, what if we just put that in our own context here in Saskatchewan? We have a student who's struggling at school and we want to assess their intelligence to see if there are any limitations in anything that we can do. And they come from Saskatoon, and they grew up in a good neighborhood, and they go to a good school, and they have all the resources that are available. Now compare that person to someone who comes from a very small community up north that maybe doesn't have all the same resources, that maybe doesn't have the same experiences, that maybe is having difficulty at school for lots of reasons other than intelligence. You give them both the same intelligence test, and we still have biases in it. In other words, can we really use our intelligence tests that we would give here in Saskatoon for a remote, say, Aboriginal community? Well, the answer is no. You have to understand the context and you have to understand the community. So it shows students, or I try and show students, how the topics we're talking about are applicable in everyday life. And then the fourth way that I try and cover material related to the topics I lecture on is through social media. So I teach through a hybrid approach. And what that means is I have a lot of material online. I have a course management system. You can access YouTube videos, newspaper articles, comics, cartoons, crossword puzzles, all sorts of different material, including experiments, questionnaires, surveys related to the material that I cover. I also have built-in online testing so you can monitor how well you're learning the material, what areas you might have a weakness in, what areas you might have a strength in, all to facilitate your learning. So that gives you an idea of how I teach. So if you come into my class, yes, you'll get a standard lecture, one. But after that, the other lectures for that topic are going to be very different. We'll watch videos, we'll watch TV shows, we'll listen to music, all to try and better understand psychology. You might have also noticed that I'm a priest. You probably won't run into very many professors here at the university who are also priests. I actually think that being a priest and a clinical psychologist are very compatible. The spiritual life, the religious life that people have is very important in understanding how they function, how they understand the world, how they cope, and maybe what I need to do as a clinical psychologist or someone trying to help them in terms of their coping or in terms of symptoms they might be presenting. As a priest and as a clinical psychologist, I can bring these two fields together. But that's not the only way that I work as a priest. I'm actually a priest from Africa, so I'm not actually even ordained or licensed in Canada. My home diocese and my parish is in Tanzania. So I'm an African priest. And every year, I return to Africa and I work there. I work there teaching psychology, clinical services, mental health services, around health psychology. I return there and I do clinical work, so actually working with patients, whether it's in a health setting or a mental health setting. I also do research there. So talking about health psychology or health issues, talking about mental health issues, what are the cultural differences? How is it that people from one culture understand mental health issues, and is that different than how people from another culture understand mental health issues? So the way my life basically works is, I'm here in September until the end of the academic year, which is around the start of December. December, I return to Africa, and I spend about a month there. I come back in January, and then I'm here for that academic year, or academic semester. And when that semester's over, I return to Tanzania again. I stay there until the end of August, and then I come back. So in this way, I combine two different worlds, two different ways of looking at physical health issues, two different ways of looking at mental health issues, in what I think is an exciting way of looking at problems. I think it also fits with what the University of Saskatchewan is trying to do: innovative learning, innovative research, outreach and engagement. So this is what I do as a psychologist, as a faculty member, and as a researcher.